I think this next session ties nicely into the last session. Many of you or your parents have needed to advocate in the realm of insurance and disability. Insurance and disability are complex and can be very difficult to navigate without the proper resources. I've spoken to many of you about insurance and disability related barriers this year, and particularly since the pandemic started. I often refer people to Triage Cancer website because it offers a wealth of current information about insurance and disability issues, including those related to COVID-19. So our next speaker is a cancer rights attorney and chief operating officer at Triage Cancer. Many of you have seen her speak before at previous events, and she has a wealth of knowledge about insurance and disability. I'm so excited to welcome back Monica Bryant. Hi, Monica. Thank you so much for being here with us again today. I hope you're not getting tired of us yet.
Hello, not at all. I'm happy to be here, and I'm always even happier when the technology seems to work right away on the first try. So now I know that the agenda called this session the deep dive into insurance and disability, but unfortunately the reality is, even though we're going to spend an hour together, we're really just going to scratch the surface. But throughout today's presentation, I'm going to point to places at Triage Cancer on our website and in events where you can continue to learn and get additional information. So for those of you who don't know, Triage Cancer is a national nonprofit that provides education on the practical and legal issues that may impact individuals after a serious diagnosis. Now, I would say about 98% of what we talk about is not actually cancer specific. It applies to all of us, and particularly people who've had any sort of serious medical diagnosis. We just happen to talk about it through the lens of cancer. So I really encourage you to share the information if you think that there are others in the community that might benefit, and just sort of ignore the cancer part in all of it. So as part of our mission, we also host events, and I just wanted to point out that we have one coming up on November 14th that will also be virtual. It's totally free, so if you want more about this insurance and finances and employment piece, that's an opportunity for you to get some more. We also host monthly webinars, and they're all recorded on our website. So even if you've missed our past webinars, like on Medicare, for example, if you're interested in that, you can just go to our website and watch the recording. And then throughout today's presentation, you're going to see links to what we refer to as quick guides. And these are our 1 to 2 to 4 sometimes page documents where they really are just a snapshot of a particular topic. They are downloadable for free on our website. So I encourage you to take a look at those as well. And I was listening to the advocacy session right before me, and I think that yes, sometimes you're going to have to be an advocate for yourself, and some of these quick guides might help you do that. Also, where you live can impact what protections you have access to, and so we have charts of state laws, because I know that we have people tuning in from all over the country today. And then finally, as much as I would love everybody to read all of our quick guides, we know that that's not necessarily a reality. So we also have some animated videos on some of the most important topics that can impact finances and quality of life after a serious diagnosis. And all of these are available in English and Spanish as well. And then we also host another tool on our website called Cancer Finances, and this has information about all of the different topics, or many of the different topics, that can impact your finances after a serious diagnosis. But what's unique about this tool is that it's in a choose your own adventure sort of format. So the site will pose questions, and based on how you answer those questions, it will take you to targeted information. And then finally, I'm going to point to a couple of different blogs that we've posted recently, because the blog is where we share late breaking news. And as you can imagine, with the current pandemic and political climate that we're in, there's actually a lot of late breaking news. And what we try to do in this blog is not just regurgitate what is in mainstream media, but really try to dissect and decipher what these how these things are going to impact individuals with serious diagnoses. So I encourage you to check that out as well. Now, financial toxicity has really become the buzz term over the last couple of years, and it refers to this idea that when somebody gets a diagnosis of a serious illness, it's not just their illness that they have to worry about, but it's also their financial health as well. And we know that while cost of care does have, a role to play in the overall financial toxicity, it's not the only thing. So this is actually a visualization of many of the questions that can be asked of someone to try and avoid financial toxicity. Now, I realize it's a lot to see right now, but if you go to this link on the bottom of the slide, you can get the full-size version. And on the full-size version, you'll see all of these questions on the left-hand side, resources that deal with answers question. So if I don't even know where to start, this might be a good place. Now, we know that health insurance status is one of the primary contributing factors to financial toxicity, but it's actually a pretty easy thing to solve with one caveat. The major problem right now is that most Americans don't understand how health insurance works or even how to make decisions between policies. And oftentimes what happens is somebody's going along their life and then they get a serious illness and then they suddenly have to become an expert in all of these things. But it can be really hard to figure out where to go to learn more. So if you are sitting there thinking, gee, I really wish I understood more about health insurance, you're certainly not alone. There have been multiple studies. This is one I just happened to pick up recently. And this one showed that of the individuals surveyed, only 4% could correctly identify the most commonly used terms in health insurance. So it is not surprising that only 40% of Americans feel very confident that they can make the right choices when posed with multiple options for health insurance. So I want to sort of step back and start at square one to make sure that we're all on the same page. Now, in this country, there are three main places we get health insurance. The largest number of Americans get their health insurance through an employer. The next largest group gets their health insurance through the government, primarily through Medicare and Medicaid. And then finally, the smallest number of Americans get their health insurance directly from a health insurance company. But regardless of where you get your health insurance, the terms I'm about to talk about are the same. So specifically the terms around costs. So the monthly premium is what you have to pay every single month just to have health insurance. And you're gonna pay that monthly premium whether you see the doctor or not. It's very similar to having car insurance all year, but never getting into an accident. But then there are some additional costs that you're going to incur when you actually use your health insurance by getting medical care. Your deductible is a fixed dollar amount that you have to pay each year before your health insurance company starts picking up their share of the costs. Now, the actual amount of the deductible is going to depend policy to policy. So some policies have a $500 deductible, some have a $5,000 deductible. It's all going to depend, but it's going to be given to you as a fixed dollar amount. Now, once you've met that deductible, the health insurance company starts picking up their share of the costs, which is referred to as cost share or co-insurance. Now, one of the reasons that health insurance is so confusing is there are often multiple terms for exactly the same thing. And this is one example of that. So co-insurance and cost share, same thing. And this is a percentage. And you're going to pay this each time you get care once you've met that deductible. So you could have an 80-20 plan. That means that once you've met your deductible, the health insurance company pays 80% and you pay 20%. Now, many plans also have an additional payment called a co-payment. And this again is going to be a fixed dollar amount, and it's going to depend on your policy, but you're going to pay that each time you get care. So for example, many policies have a $25 co-payment when you go and see the doctor, or a $30 co-payment to see a specialist. And then finally, your out-of-pocket maximum. Now, this is probably one of the most important things you can understand about your policy, because what this number is in a worst case situation, the most amount, or the most you're going to pay out for your healthcare in a given year. And the way that you get to your out-of-pocket maximum is by adding up your deductible anything you pay towards your co-insurance, and anything towards your co-payments. So it's everything you're paying out of pocket except those monthly premiums. So here's an example of how this all works. Meet Dan. Dan has a plan with a $2,000 deductible. It's an 80/20 co-insurance and an $8,000 out-of-pocket maximum. Let's assume he hasn't received any other medical care for the year. He ends up in an accident and gets a $102,000 hospital bill. So what does he have to pay? The very first thing that Dan has to pay is that deductible. So we subtract the $2,000 he's paid from the bill, we're left with $100,000. Then we know his co-insurance amount is 20%. Well, 20% of $100,000 is $20,000. But does he have to pay that whole $20,000? The answer is no, because he has that out-of-pocket maximum. So he's already paid $2,000 of his deductible, so he has to pay another $6,000 to meet his out-of-pocket maximum, and then the insurance company is responsible for the remainder of the bill. Now, I am not suggesting that $8,000 isn't a lot of money. Of course it is. But when we start looking at the alternatives, like having to pay $20,000 if there was no out-of-pocket maximum, or even the $102,000 if he didn't have insurance at all, it starts to feel a little bit more reasonable. Now, I will say that the devil's in the details with this. So typically, only payments made towards in-network providers are going to be counted towards that out-of-pocket maximum. Also, some employer plans have a different way of calculating that out-of-pocket maximum. So for example, my employer plan doesn't include co-payments in the out-of-pocket max, but it does include deductibles and co-insurance. So if you have an employer plan, it is important to look at that specific plan to see how they're going to calculate the out-of-pocket maximum. Now, if you would like to hear what I just talked about in terms of the terms or this example, that is included in our animated video on health insurance basics. And even if you don't want to hear it again, if you know somebody who might benefit from hearing it, please feel free to share that with them. Now, because I was only given an hour to talk to you, we're not really going to delve deep into Medicare, but I do want to just mention that Medicare is the federal health insurance program that is for individuals who are over the age of 65 or have been receiving Social Security disability insurance for 2 or more years, or have end-stage renal disease or ALS. Medicare is incredibly complicated and confusing, but we have several resources to help you try to navigate Medicare, including a webinar I just did last month that's archived on our website. And we have 3 different quick guides talking about Medicare, and there's also a whole module on cancer finances as well. So if you have Medicare questions, check out those resources, and you can always feel free to reach out. I'll be in the Slack channel later, or you can always email me. Now, in 2010, a law was passed called the Patient Protection and Affordable Care Act, otherwise known as the Affordable Care Act or ACA or Obamacare, all the same thing. Now, this is a behemoth piece of legislation. It's over 1,000 pages long. There have been federal agencies and state agencies putting out regulations. There have been court cases. So to explain the Affordable Care Act in total is almost impossible in one sitting. Today, I really just want to focus on some of the new benefits the ACA has given us as consumers and some of the new health insurance options. So if the ACA did nothing else except the 2 things I'm about to talk about, it still would have been game-changing for individuals with pre-existing conditions. So the first thing the ACA did was it limited what insurance companies are allowed to look at when they're deciding what they're going to charge someone for insurance. And that's referred to as premium rating. So as of January 1st, 2014, insurance companies can only look at 4 things. Are you buying an individual or a family plan? The more people you have on it, the more expensive it can get. Your geographic location, and it's based on zip code. Your age, so yes, the older you get, the more you can be charged, but there's now a cap on how much more you can be charged. And then in most states, if you use tobacco, you can also be charged more. So the 2 sort of most important things you don't see here are, of course, pre-existing conditions. They can't use that to decide they're going to charge you more. And gender. Prior to this law being passed, women were charged more for the same health insurance policies than men were. So that's the first piece. The second piece said that health insurance companies can no longer deny selling somebody a policy or covering services related to a pre-existing condition. And I know we've now had this for 6 years, and I think many of us have sort of gotten comfortable with this idea. It is truly a huge change in the system. Now, there have been multiple efforts to repeal or change the Affordable Care Act. But in all of those efforts, elected officials said, but we like the pre-existing condition piece. When pushed, what we learned was what they were talking about was number 2, not number 1. The problem with just keeping number 2 and not keeping number 1 is that it's not really a protection and access to care for me if they can charge whatever they want related to my pre-existing condition. So in our opinion, in order to truly stay a protection, these two provisions have to stay coupled together. Now, there have been all sorts of things happening, which I'll get to in just a few minutes, about where these protections are going. Now, one of the other things that the ACA did that was incredibly important was dealing with when an insurance company says no. So most of the time, once somebody gets a serious diagnosis, at some point along the continuum of care, they're going to end up with a denial from a health insurance company. The good news is that as consumers, we don't have to take no for an answer. There are generally 2 different levels of appeal. An internal appeal is when you go back to the insurance company and say, please reconsider. But then there's also now an external appeal in all 50 states. And that's thanks to the ACA. So some states had it before, but the ACA made it nationwide. Every state has the ability for you to go to an independent entity and ask for them to look at your case again. And that's referred to as an external appeal. It's different in every single state, but if you go to our state resources page and click on your state, you'll see the entity that's in charge of doing external appeals in your state. Now, what's unfortunate about this is it's one more thing put on the burden of patients and caregivers to have to deal with. The good news is we know that somewhere between 40 and 60% of all appeals are decided in favor of the patient. So roughly half the time when an insurance company is saying no, they're getting it wrong. So it really is in our best interest to appeal denials of care. And of course, we have tons of resources to help you do that as well. Now, Medicaid is the other federal health insurance option. It's for individuals who have lower incomes. Now, prior to 2014, in order to access Medicaid, you had to have a low income and a low resource level, which are things like savings accounts or retirement accounts, and be able to walk through one of these 4 doors. Most of the time, communities that I'm talking to were walking through this left-hand door through the Age, Blind, and Disabled program. Terrible name, I know, I didn't name it. The challenge with that is A, it was forcing people further into poverty by eliminating any sort of savings or retirement or safety net with this resource test. The other problem was this was an incredibly high definition of disability. So really people were left without options. The ACA created a new door or a new category that was just based on income level. And it's based on having an income at or below 138% of the federal poverty level. And I've given you the dollar figures here. So there's no more asset or resource test. So the original 4 doors still exist and still have the income and resource test. It just added a 5th door. Now, this was supposed to happen across the country. It was going to reduce all sorts of disparities and provide access. And then the Supreme Court got their hands on the ACA and essentially made the decision to expand Medicaid voluntary for states. And this is where we are right now with 39 states expanding and 38 states in DC expanding and 12 states not expanding. But all these footnotes you see are states that have come on to expansion after the original time period. This is probably the slide that changes most often because as governors change and legislatures change, states go back and forth in all of this, which just sort of adds to the complexity for us as consumers. Now, the ACA also created a new way for us to shop for health insurance, and that was through the state health insurance marketplaces. When the law was first passed, these were called exchanges. Turns out no one knew what the heck that meant, so they renamed them insurance marketplaces. No one really knows what those mean either. The biggest misconception about these marketplaces is that it is government insurance. It is not government insurance. It is private health insurance companies selling their plans or policies through the state health insurance marketplace. So the easiest way for me to think about it is it's like a shopping mall for health insurance or Amazon for health insurance. What you're buying is still the product from the insurance companies. You're just doing it through the marketplace. So people typically ask, well, if I'm getting insurance from an insurance company, why wouldn't I just go to the insurance company? Why mess with these marketplaces at all? The reason is to potentially for shopping through. First, actually a cap on how much the out-of-pocket maximum can be. So for this year, the out-of-pocket maximums cannot be more than $8,150 for an individual or $16,300 for a family. Now, I realize those are very high numbers, and I will tell you over the last 2 years, we've seen the biggest jumps in these numbers. We don't yet know what it's going to be for 2021. The other benefit potentially is that there might be financial assistance to help you purchase a policy through the marketplace, and that's going to depend on household size and income level. And if you want to know more specifics about that, we have that information on our website. The other benefit to buying in a marketplace is that all of the plans are standardized based on their cost share. And they're standardized by metals. So a bronze plan is going to be one where the insurance company picks up 60% of your healthcare costs and you pick up 40. Silver is 70-30, gold is 80-20, and then platinum is 90-10. So typically with bronze plans, you're going to have the cheapest monthly premium, but then the highest deductible and out-of-pocket maximum. Platinum plans are going to have the most expensive monthly premiums, but the lower deductibles and out-of-pocket maximums. So what's really helpful about this is someone who, let's say, is healthy, never sees the doctor, just wants basic coverage, can go into the marketplace and just say, just show me the bronze plans. Conversely, for many of the people I talk to in the cancer community who see the doctor every 37 seconds, it's more like, only show me the gold or platinum plans because I know I'm going to be accessing healthcare frequently. So it just helps us weed out the information that's not pertinent to us. Now, when you can pick up one of these policies is going to depend on what type of policy we're talking about. So Medicaid applications are accepted year-round. As soon as somebody becomes eligible, they can apply. Marketplaces have annual enrollment periods, and we are coming up quickly on the enrollment period for 2021 in most states. That's going to be between November 1st and December 15th of this year. I say most states because some states, like California, for example, run their own marketplaces. And so they have control and may have longer open enrollment periods. So if you want to see what's happening in your state, check out the chart of state laws. We have all of those dates listed for you. Now, Medicare also has an annual enrollment period that is starting very soon. It's from October 15th through December 7th. Now, marketplace plans and Medicare plans are calendar year plans, which means even if you pick a plan day 2 of open enrollment, that plan won't start until January 1st of 2021. So important to remember to keep coverage through the end of the year. Now, employer plans vary. They can have enrollment periods at any point during the year based on their plan, but most employers have a fall open enrollment to be the same sort of calendar year start date, but you do have to check with your employer. Now, the good news is that the ACA recognized that things don't just change during open enrollment period. And so they created a special enrollment period. And this is if you have a life-changing event that either results in you losing coverage, like let's say you're leaving your job, or your family or where you live has changed. it triggers this special enrollment period, which gives you 60 days to shop for a new policy in the marketplace. So what that means now is that if somebody's losing coverage through their employer, they have more options than ever. So it could be picking COBRA or state COBRA, which I know we didn't talk about today, but we have resources on. And essentially it's the exact same health insurance policy that you had through your employer. You're just paying a lot more for it. Lane 2 is picking a totally new plan in the marketplace special enrollment. Lane 3 might be that you're eligible for another group plan, like a spouse's plan, or if you're under the age of 26, a parent's plan. Or maybe now you're eligible for Medicaid or Medicare. So we have more options than we've ever had in the past thanks to the ACA, but the challenge with this is you have to pick a lane and stay in it until the next open enrollment period. You don't get to switch back and forth between lanes. Now, I realize that I went over that rather quickly, but please know we have 2 resources hot off the presses in the last 4 weeks about what happens if you lose employer-sponsored health insurance. So we have our quick guide and we have an animated video. And I know that this is becoming more and more relevant, unfortunately, as more and more people are losing their jobs as a result of COVID-19. So again, if you know of people who might benefit from learning more about their options, please feel free to share. So I mentioned we have more options now than we've ever had. Great. That doesn't solve the problem of, well, how do we actually make choices? I'm going to give you an example using the marketplace, but the analysis is exactly the same if you're trying to compare between 2 plans your employer might offer. If you're trying to decide, well, do I take my employer plan or is a marketplace plan better for me? Or even if you're trying to decide between 2 Medicare plans, it's the exact same analysis. So here I have 3 plans: a bronze plan with, $173 monthly premium and a $6,000 out-of-pocket maximum. A silver plan with a $271 premium, a $5,200 out-of-pocket maximum, and then a platinum plan with a almost $400 a month premium and an $1,150 out-of-pocket maximum. So again, in this scenario and in the communities that I spend a lot of time speaking to, chances are you're going to hit your out-of-pocket maximum for the year. So knowing that, which plan is going to cost me the least at the end of the year? You typically can't just tell by looking at this information. You actually have to do the math. And the way that you do the math is you take that monthly premium and you multiply it by 12, because that's how much you're going to pay in premiums for the year. And then you add the out-of-pocket maximum. When we do that math, we can see that that platinum plan that seemed really expensive in its monthly premium ends up being over $2,000 cheaper at the end of the year. Now, I will say we do this presentation probably 100 times a year, and it never comes out the same twice when we go to different states. But the important piece here is that sometimes we can get sticker shock with that monthly premium, and that isn't only a piece of the puzzle. We have to do the math to figure out how much is it going to cost us for the entire year. But that's not the only thing we need to look at. We also need to look at, well, what's the deductible? What are the co-payments? For example, you might have a plan that's going to be less expensive come the end of the year, but it has a $6,000 deductible. Well, now you have to come up with $6,000 right away, whereas perhaps another plan has a $0 deductible. So yes, you're paying more in monthly premiums, but most of us can pay a little bit more over every month as compared with writing a big lump sum check. Also, it is imperative that you check that your doctors and providers and labs are all in the plan's network, because that plan is only going to be affordable if you're going to in-network providers. And then finally, checking the prescription drug coverage. So are all of your prescription medications covered under that plan? Maybe there's another drug deductible. It's just very important to know how that plan is going to treat your prescription drugs. Now, the unfortunate piece of all of this is it is not a one-time chore. We have to review our options every single year to make sure that the plan we're picking for the year ahead will in fact meet our needs. And I generally think it's important to talk with your healthcare team around this time of year to see if they anticipate any changes in the year coming. So for example, doctor, are there any prescription drugs that I'm not on right now that you anticipate me being on in the next year? Because then you're going to want to make sure that whatever plan you pick also includes those prescription drugs, even if you're not on them right now. Now, there's a couple of pieces that I want to talk to you about that are really, I think, important in this exact moment. The first is that there has been an increase in the sale of short-term plans. These plans were originally designed to help bridge gaps for people. So like leaving job A and going to job B, but job B has a 60-day waiting period before your benefits kick in. Someone could get a short-term plan and it would sort of just tide them over. These were supposed to be very limited under the ACA because they don't have to comply with all the ACA's protections. So they can charge people more for having a pre-existing condition. They can exclude entire categories of care, like prescription drugs. It doesn't count as creditable coverage. So if it ends mid-year, which many of them do, it doesn't trigger that special enrollment period I was talking about. So really challenging for us as attorneys and healthcare rights attorneys, because people will come to us and say, my health insurance company isn't going to cover my chemo. And we say, wait a minute, that's not possible. And then we look deeper and we realize, oh, you have a short-term plan. They're allowed to do that. As I mentioned, these plans were supposed to be limited. In 2018, Health and Human Services under this administration expanded the availability of these policies. So now they're allowed to go up to 364 days. So that's 1 day short of having to comply with the ACA. They're renewable, but it's not required. And the other piece about this that's incredibly hard is that it's not necessarily obvious to consumers that what they're buying are short-term plans because they have the same kinds of names that all of these other plans have. So you could have like a Blue Cross Healthy America 2000 plan and not know that it's necessarily a short-term plan. The other piece that's very challenging is that these plans were not allowed to be sold through healthcare.gov, which is the federal marketplace, until 2018. They are now being sold on the marketplace. So we just want people to be aware of them, that if they're going to the marketplace, come open enrollment, to make sure that they aren't picking a short-term plan unless that's what they want to be doing. So that's the first issue. The second issue is that there is currently a court case pending in the Supreme Court challenging the constitutionality of the ACA. So for the sake of time, I'm not going to go into too much detail about this, but so you understand the timeline. In 2017, Congress reduced the penalty for not having health insurance to $0. That triggered a chain of events where the Texas Attorney General and 17 other states' attorneys general and 2 individuals challenged the constitutionality of the ACA. The Department of Justice, which is the federal entity that is supposed to defend federal laws in court, said, we're not coming to court. But there are parts of the ACA we can keep. The next day, the California Attorney General and 16 other states' attorneys general asked the court, can we step in instead of the Department of Justice and defend the law? So you've got states' attorneys generals on both sides of this case now. December of 2018, the Texas judge ruled the ACA unconstitutional. It was appealed up to the Fifth Circuit. Now the Department of Justice in February is saying, you know how before we said some of it was okay? Now we disagree, strike it all, get rid of all of it. In July, the Fifth Circuit heard the case, and in December of last year, the Fifth Circuit upheld the decision and sent it back down to the lower court, saying that it was in fact unconstitutional, and asking that lower court to decide if any of those other pieces could be kept of the law. Well, it almost immediately got appealed up to the Supreme Court. Of course, we ended up in a pandemic, so there was no oral arguments. The Supreme Court said that they were going to hear oral arguments on November 10th, and of course, 2 weeks ago, Justice Ruth Bader Ginsburg passed away, so there's now an open seat. So all of that is to say, there's lots of flux here. And there are actually 6 different scenarios, and we've written extensively about these scenarios in our blog. But one of the reasons that I'm talking about it right now is because that directly impacts our ability to access health insurance. And if you're sitting there thinking, well, I have employer-sponsored insurance or I have Medicare, so this doesn't really impact me, I beg to differ, because the ACA actually touches every aspect of our healthcare system. So we do have some ability to have a say in what happens. And so if this is something that you care about, I definitely recommend that you talk with your elected officials, whichever side you happen to be on, and certainly go and vote. So I'm piggybacking a little bit on the last session's advocacy message. But this is so complicated and convoluted that many Americans don't really know that this is even happening. And so we take a few minutes to try to sort of walk you through it. And of course, if you have any specific questions, feel free to reach out. So with that, I'm going to switch gears and talk a little bit about work and either working through treatment or taking time off or stop working. So we often find that employees are battling one. So they're battling assumptions of work that can help. They might be battling their employer's assumptions. Oh, my employee can't work now and there's nothing that can help. And we hear a lot that they're battling their healthcare professionals' assumptions that their patient can't or wouldn't want to work, so they should just go out on disability leave. But the reality is many people either need to work or want to work, and they might be able to based on using tools that are available to them. So there are a couple of different places that we can go to find our employment rights. There are both state and federal fair employment laws that not only provide protections against discrimination, but may also provide some other tools. There are both federal and state and city and county leave laws. And then if you are an employee working under some sort of contract, like an employment contract or a union contract, those contracts may provide additional or different rights and benefits. But it is important to remember that the law is just the bare minimum of what employers have to provide. And many employers are in fact much more generous than that bare minimum. So really important to look at your employer's specific policies to see if there are things that they're providing you that might be helpful. Now, one of the tools that I mentioned that is available through the Federal Americans with Disabilities Act is reasonable accommodations. And I've given you the big long definition of it, the legal definition of it, but the easiest way to think about reasonable accommodations is by giving some examples. And we can put these examples into 3 categories. The first is about your physical space. So maybe it's about, if you're dealing with fatigue, moving to, moving an office closer to the elevator or a closer parking spot or accessible work equipment, or it could be about telecommuting. And telecommuting could be about working from home, like many of us are, or it could be about working from a different location. So somewhere where there's less exposure or less of a commute. So that's about the space. The second category is about schedule. So maybe it's about working part-time or a flexible schedule. So instead of working 5 8-hour days, you're gonna work 4 10-hour days. Or instead of 9 to 5, you'll work 7 to 3. It could be about extended leave, which we'll talk about in just a moment. And then it could be everything else. So using technology like speak type software, if that's an issue, changing policies, shifting responsibilities, or it could be moving to another job entirely. Now, reasonable accommodations are one of the most important tools for individuals who are trying to either work through treatment or return to work after treatment and are still experiencing late or long-term side effects, but they are often underutilized. So to that end, we have lots of resources that can be helpful, including a quick guide and a checklist and one of our animated videos. So I encourage you to take a look at those. But the reality is, many times you're going to need to take time off, either for a short period of time or an extended period of time. And of course, there are both federal and state laws and employer policies that might allow you to do that, and we have more information about all of that. But I was specifically asked to spend some time talking about disability insurance today, so that's where we're going. Disability insurance is an insurance policy that makes up for lost income. So it could be that that money needs to be spent on medical expenses, but it doesn't have to be. It's really about paying for anything that you need to pay for, like housing or food or bills. There are several different types of disability insurance. So there's private disability insurance. So you go straight to a company and purchase it yourself. There's some that you get through an employer, and sometimes employers will pay all or part of the premiums. I can't tell you how many times people call us and they say, I don't have disability insurance. And we say, well, did you check with your employer? And then they go back and realize, I didn't know. I signed paperwork on day one and I didn't know I had access to that. There are both short-term and long-term policies, and the specifics are going to be found in the policy itself, but generally, short-term policies are going to be for disabilities that are going to last up to 6 months, long-term are for disabilities that last 12 months or longer. There are a handful of states that have state disability insurance policies. Again, the details vary state to state, but we have a quick guide on that for each of the states. And then, of course, there is the federal disability insurance program. This is run through the Social Security Administration. Both programs are long-term disability insurance programs. So we're going to talk about Social Security Disability Insurance, which is SSDI, and Supplemental Security Income, which is SSI. But for both programs, SSDI and SSI, in order to access the program, you have to meet the Social Security Administration's definition of disability, which is you cannot do your job, you cannot adjust to a new job, and your disability has or is expected to last for at least 1 year or result in death. So it is literally the highest standard of disability that exists. What's really interesting about this program is that while it's a federal program, it relies on state agencies to make the determination of if somebody has a disability or not. So that does lead to some inconsistencies state to state about what qualifies as having a disability. But we often get asked, well, can I apply for disability insurance while I'm still working? And the answer is it depends, because the very first step in the disability determination process asks, are you working and earning more than $1,260 per month? And that's what's called the substantial gainful activity amount for this year. That amount changes every year. So if you are working earning less than that amount, you could actually still qualify for SSDI. So it's a misconception that you can't work at all while being on disability. Now, even though SSI and SSDI have that same high standard of having a disability, the differences in these programs are key. For SSI, it's about having a low income level and a low resource level and falling into one of these specific categories. For example, being over 65, having blindness, or having a disability. Hopefully, that is ringing a bell and reminding you of the standard to access the original 4 doors of Medicaid. SSI does not provide a whole lot of money. The federal maximum amount for this year is $783, but some states do add money on top of that. Now, in many states, once someone becomes eligible for SSI, they are automatically eligible for Medicaid. So SSI is going to give money to pay for things like housing and food. Medicaid is going to cover healthcare expenses. Compared with SSDI. SSDI isn't about your resource level at all. It's rather about, have you worked and paid into the system? And I've given you the breakdown here, but generally you need 40 credits and you earn a credit each quarter of the year. And 20 of those have to be in the last 10 years. So not only do you have to have worked and paid into the system, you have to have worked recently enough to be eligible. Now, what's interesting about SSDI is the amount that you get paid is based on how much you've paid into the system. So someone who has consistently been making $100,000 a year is going to get more than someone who's making $40,000 a year. But the amount is capped, and this year it's capped at $3,011. So even if you're Bill Gates and you're applying for SSDI, you can't get more than that $3,011. Now, there are several challenges with these programs. The first is that they are not speedy. So it can take sometimes 14, 16, 24 months before your application gets approved. So the Social Security Administration acknowledges that and will actually provide back pay from the date the application is approved back until the date of the application. And back pay is available both for SSI and SSDI. With SSDI, in addition to back pay, you're also entitled to retroactive pay, which is the time between what's referred to as your disability onset date. So that's the date that the Social Security Administration deems your disability to have started, up to the application period. But it excludes the required 5-month waiting period. So there is no way to get past this 5-month waiting period. Everybody has this 5-month waiting period. There's lots of bad information on the internet about ways to get around the 5-month waiting period. It's just not possible. That being said, there have been some advocacy efforts to try to eliminate this 5-month waiting period. So again, if you're interested in advocacy, feel free to reach out and I can point you in the right direction. Now, once somebody has been receiving SSDI payments for 24 months, they become eligible for Medicare. So as I mentioned, the 2 main ways to become eligible for Medicare are being over the age of 65 and being on SSDI for 2 or more years. Now, unfortunately, this system is slow, and over 70% of applications are denied on the first try. The good news is, just like in health insurance, there is an appeals process. And again, it's sort of unfair that it's all being sort of put on the shoulders of the patient and the caregiver, but it is good to know that you don't necessarily have to take no for an answer. Now, I often get asked, well, do I need to hire an attorney to go through this application process? And I would say it's not required, but if you are considering appealing a denial, it can be very helpful to get a disability attorney. Now, sometimes people will say, well, wait a minute, I'm not working, I have no money, how am I going to pay for an attorney? The good news with this is that for Social Security appeals, attorneys are paid on a contingency, which means they only get paid if you win, and then they only get a percentage of your back pay. And the percentage is capped. It's 25% of what the back pay that you got, and it's capped at $6,000. There are a lot of scams out there around disability attorneys, I'm not gonna lie. So definitely go to a reputable entity to start your search, the American Bar Association or a local bar association. The National Organization of Social Security Claimant Representatives, don't ask me how you say that acronym, I have no idea. They have a tool that you can put in your zip code and find representatives near you. Now, I did just want to spend the last couple of minutes talking about how all of these different laws and protections and benefits can actually fit together. So the FMLA is the federal law that gives us job protected time off. It's unpaid. So if somebody has access to disability insurance, it can be very helpful to use FMLA in conjunction with disability insurance. But what I'll hear from people is, listen, I know I'm not coming back in the 12 weeks that the FMLA gives me, so I'm just gonna leave now and not bother with it. It still might be useful to take that FMLA because in addition to providing job protection, the FMLA requires employers to continue paying your health insurance. So that's 3 less months that you would have to figure out how to pay for your health insurance. So this is how it sort of all works together. So Jane's doctor suggests she goes out on disability, but she also has 3 weeks of vacation, 3 weeks of sick time. Her employer is covered by the FMLA, and she has a short-term disability policy that lasts up to 12 months. So the first thing Jane does is she takes that FMLA leave for 12 weeks, which is job protected leave, but it's unpaid. So she can take her sick time and her vacation time at the same time as her FMLA. So what's happening is the green here is providing the job protection, and the blue is providing her money. And then, oops, oh no, sorry, went the wrong way. And then to figure out what she's going to do even after that vacation time, she can use her short-term disability, which again provides you no sort of job protection. It's just about making up for your income. Now, same thing here with Mark's situation. So Mark thinks that he is going to need to be out for 15 weeks, but remember, FMLA is only 12 weeks. And my animations are all screwed up today, so I'll just do that for you. So in the you can see laws that allow you to take the job leave for the first 12 weeks, and then he can actually ask for additional time off as a reasonable accommodation under the ADA for those additional 3 weeks. And then the blue here shows us how he's going to get money during that time that he's off. He's going to use up his vacation and his sick time, and then he's going to use his short-term disability. So this is where we see people really get confused because we're in the weeds. But it is important to sort of understand what are all the different puzzle pieces that you have and how can we fit them together to give you the most amount of protection. Now, the other thing that we hear a lot from people who are already on Social Security disability insurance programs is, I want to try to go back to work, but I'm scared that I might not be able to, and I won't know that until I try, and I don't want to lose my disability benefits. It was already so hard to get them, I don't want to lose them now. The good news is that the Social Security Administration has a plan. They have these programs, collectively referred to as work incentives, that allow you to keep Medicaid or Medicare, if you have one of those, through these programs, and continue earning some benefits through SSI or SSDI, but also try to go back to work. And so the Ticket to Work is a great example of that program. So if you are thinking about returning to work, but you're concerned about losing your benefits, I strongly encourage that you check out these Social Security Administration programs because they can be really quite helpful in helping you transition if that's what's in your plan. Now, of course, we cannot ignore the elephant in the room that is the pandemic we are currently experiencing, and that has resulted in some additional pieces of legislation, both at the federal and state level, and lots of questions. We have released several blogs on these issues. We have some information about different state laws on our charts of state laws. And then we have recently created a new module on cancer finances specifically around work and health insurance and even caregiving with respect to COVID. So if you're interested, feel free to take a look. And as promised, we really only scratched the surface on all of the different topics that you might be dealing with right now. And so these are all the categories of topics that we have resources on at Triage Cancer. So I strongly encourage you to check them out if you are interested. And I look forward to your questions now and in this Slack later if you have them.
Thank you, Monica. Just as in our previous presentation, just such a wealth of information, and we can't thank you enough for being here again. We really always appreciate what you bring. So we will open it up to questions. I do have one that says, you mentioned if you make under a certain amount of money per month that the individual might still be able to get disability as an SSI. Does that apply on the state level or federal level?
So SSI is a federal program, so I'm not entirely sure I understand the question. So state disability insurance programs have different requirements. And again, we have that quick guide that talks about the 5 different states requirements. But if you're specifically talking about SSI or SSDI, those are both federal programs.
Okay, thank you. And if you want to clarify that question, Jack, go ahead and retype it if we didn't get that answered appropriately for you. I have a few questions that I jotted down, and wondering if you have suggestions for our younger adults that will be, or maybe not younger, those that are getting close to 26 that are going to be transitioning from pediatric care off of their parents' insurance policies to their own. So can you speak to that at all and what might be helpful to them?
Sure. So many of the things that I talked about with respect to losing employer-sponsored insurance are going to apply if you're aging out of your parents' policy. So it could be about electing COBRA or state COBRA to keep the exact same policy that you had under your parents. It could be about picking up a totally new policy in a marketplace through your state. If you're going to work, it could be about getting an employer-sponsored policy through your job. If you're getting married, it could be about getting on a spouse's plan, or depending on your circumstances, you might be eligible for Medicaid or Medicare. So I would encourage someone who has that question to look at the quick guide on losing employer-sponsored insurance, because it's all exactly the same if you're losing your parents' insurance through their job.
Okay, great. Thank you. And you mentioned the 50% positive appeal rate. And I'm wondering if you have advocates that will help individuals that are going through that or thinking about going through that appeal process. Do you have patient advocates to walk them through that?
So at Triage Cancer, we don't, because we're primarily focused on education, but we do have tools to help them. And generally, the very first stop for someone who gets a claim denial is to go back to the healthcare team and to talk with, if there's a social worker or a financial counselor available that can help them and point them in the right direction. For a lot of rare diseases, the reasons for denial are the same over and over and over and over again. So social workers, for example, sometimes navigators or nurses, it all just sort of depends on how your healthcare team is made up. But they often have the tools and the resources and the coding language and the supporting materials to help you with a successful appeal. So I would definitely recommend that being your first step.
Okay, great, thank you. And this is a little bit along those lines. When folks are looking to deciding on a plan that they're going to purchase, I guess this would be on their own. Do you recommend local insurance agents for them to seek help from? And if so, is there criteria to use to choose those?
So a very, very general rule of thumb for me is I don't recommend brokers. The reason is brokers have a vested interest in you purchasing certain plans because that's how they get paid. Brokers are also not legally required to tell you about other options that may actually be better for you. So for somebody who's trying to figure out, what their options are and they need some sort of one-on-one assistance, what I would recommend is looking for a marketplace in-person assister. And if you go to healthcare.gov, I think it's --local help, I'll find the exact link and I'll put it in the Slack after we end today, the exact link for this. But if you go to this website, healthcare.gov, and you put in your zip code, it'll show you both agents and brokers in your area. You can uncheck brokers to just see the in-person assister organizations. And they are unbiased. So they are paid through grants from the federal government, and they have no vested interest in you picking one plan over the other. And so I feel like that's really important in this day and age, especially when somebody has a rare disease and they're going to have very specific requirements and needs.
Absolutely. Okay, thank you. We do have a question from one of our attendees. Faith is asking, can you comment with any knowledge about pre-existing conditions and what could happen to your coverage if provisions for that are dropped by insurance companies? Example, is it just that they, let me try to decipher this, that
Charge, probably.
Can you see it?
Yeah.
Yeah.
So I'm assuming what you're referring to is if the ACA is overturned and insurance companies no longer have the requirement to provide coverage for someone who can afford it, what happens? It's a big unknown. There are sort of two schools of thought. The first school of thought is, well, if you've signed up with a health insurance company, even through the marketplace, you've essentially signed up for that contract year, and you're now in a contract with that health insurance company. So in theory, you would have that insurance for the next year. The flip side of that is one of the things that the ACA also prohibited was what's called rescissions. So insurance companies prior to the ACA, when somebody got sick and were going to cost a lot, they would go back into an original application and look for any mistake or omission and use that as a reason to cancel your policy. So if the ACA goes away, so does that protection. And so then we're in a situation where, well, our insurance companies who know now that you have a pre-existing condition going to find a reason to drop you. And so it's very concerning for us all because there are no guaranteed answers if the ACA goes away. Also, I cannot imagine a world where if the ACA goes away, that insurance companies don't go to a place where they're looking at pre-existing conditions to determine what they're going to charge you, if they're going to sell you a policy at all. That being said, there are some states that have started passing state laws that have similar protections to the ACA to try to deal with this idea of like, if the ACA goes away, what are we going to do? But none of them are as protective as the ACA.
Power in voting, like you said earlier.
Yes, yes. And I mean, I feel so doomsday about all of this, but you know, in my opinion, it shouldn't be a political issue. And unfortunately, it really has become one. And I think that there are, I think I just read something like 133 million Americans have a pre-existing condition. And so we're talking about a significant amount of the population that's impacted by what happens at the Supreme Court.
Yeah, very much so. Okay, let's see. I have another question. Let's see. Can you speak to compassionate allowance, what that is?
Sure. So within Social Security Administration, they have a program called the Compassionate Allowances List, which is a list of diagnoses that are presumptively eligible or will presumptively be deemed a disability. So the way that I think about this is with SSI and SSDI, there are these incredibly high hurdles that you have to jump over to get access into the program. If you have a diagnosis that's on the Compassionate Allowances List, that one hurdle just gets a little bit lower and a little bit easier to jump over. But you're still going to have to meet the definition of disability, even if you have a diagnosis that's on the Compassionate Allowances List. So you still have to be unable to do your job, be unable to do any other job, and have a disability that's keeping you from working and is expected to last for a year or longer or result in death. So if you do have a diagnosis that is on that compassionate allowances list, it's really helpful to make sure you write that diagnosis exactly as it appears on the list, because computer software does the initial run for all of this. And so that's a little tip or trick for you. But there's a lot. I just saw an article that incorrectly said that being on the compassionate allowances will allow you to bypass that 5-month waiting period, and it does not. It just makes that entry point a little bit easier.
Okay, good to know. And to your knowledge, are very many rare diseases on that list?
Yes.
Okay, great. That'll be great.
I will, so I'll put that link in too. So you can actually go to the Social Security Administration's website and see the whole list. So I'll put that link in the Slack channel as well.
And Matt, I think that just answered your question, so you can go to that link when it gets put in there. Okay, I have a question about Medicaid waivers. Can you speak to them, what they are, and are they available in all states?
I would like a little more information because they could mean a couple of different things. So if you could further clarify that question, I'd be happy to try and answer it.
Okay, we'll see if that person will. It was actually Jordan.
Oh.
My cohort, Jordan. So maybe if she can expand on that a little bit, I think she has some experience with it.
I can do that right now if you want.
Yeah.
Yeah, so Monica, you know, I just know on our website we have some information listed about Medicaid waivers, and really if people don't qualify maybe for full state Medicaid initially, are there still waivers available for people to maybe get some other care taken care for by the state?
Okay.
Does that make sense?
That's for clear, that's not going. So it's very state specific. So different states have different programs. So for example, some states have what they refer to as spend down. So, and this is particularly important in the states that have not expanded Medicaid. So what they could require is, let's say the reason you're not eligible for Medicaid is because you have too much in a savings account or you have a retirement account. They could require that you spend that amount down in order to access Medicaid, or that you're going to pay a portion of your care and Medicaid's only going to pay a different, you know, the other portion based on your assets. So it's hard to talk about it generally because every state is so specific. But I would recommend for anybody who isn't sure if they're eligible for Medicaid or not, to start at healthcare.gov and answer the questions, because there are some people that are right on that cusp of being eligible for financial assistance or being eligible for Medicaid. And so based on that, depending on which route they want to go, there's some strategies that can be utilized. And again, for specific cases, feel free to reach out.
Great, thank you. All righty, well, I think that's it for our questions. And again, thank you for the absolute wealth of information. I know it's a lot to digest, everybody. Take your time, go to the website, utilize the links that are there, and it sounds like you'll have your contact information in Slack if it's not already there. So thank you again for being here. We really, really appreciate it, Monica.
Thank you so much for having me. I hope you have a wonderful rest of the conference.
Okay, great, thank you.